This is a session that's going to cover all matters healthcare. And given some of the points made in the last session, this is a nice follow-up. My name is Anup Malani. I'm a professor at the University of Chicago Law School. I want to introduce our panelists before we dive in. So starting third to the right of me from your perspective is Rachel Glennerster. She's an associate professor of economics in the Division of Social Sciences here at the University of Chicago. Before she came to the University of Chicago, she was the chief economist at the Foreign, Commonwealth, and Development Office and at the Department for International Development in the UK. To my right here from your perspective is John Hewko, who's a Marshall Scholar from 1979. He's the General Secretary and CEO of Rotary International. Before that, sometime back, between 2004 and 2009, he was the Vice President for Operations and Compact Development for the Millennium Challenge Corporation, a U.S. agency that was established to distribute foreign assistance to some of the poorest countries in the world. To his right is Alex Oshmyansky, also a Marshall Scholar, 2005 class. He is the founder and CEO of the Mark Cuban Cost Plus Drug Company, which Alex helped found. He also, I like to think, is overly educated. He's got a doctorate. He's got a medical degree from Duke and a DPhil in mathematics. And then last, but certainly not least, is Meena Seshamani, who is a Marshall Scholar from 1999. She is both a doctor and a PhD economist. She is the Deputy Administrator and Director for the Center for Medicare and Centers for Medicare and Medicaid Services. And before that, she was a head and neck surgeon at MedStar Georgetown University Hospital. Okay, so we have some folks on the panel that are directed at domestic healthcare policy, and some that think about international healthcare policy. So we're gonna do a little bit of both, but I'm gonna start international and then come back to domestic. So let me, if you don't mind, start with Rachel. You, Rachel, have done remarkable work to push forward the concept of advanced market commitments in order to generate investments in public health interventions, especially those targeting infectious diseases and in lower income countries particularly. Can you, for the audience, explain what advanced market commitments are, why are they necessary, and what the successes so far have been?
Yeah, happy to. So the idea of an advanced market commitment is a way to stimulate innovation in an area where there's a big social need, but it might not be profitable for markets to work on that innovation. And it does it in a way that avoids many of the problems that we have with the patent system. So specifically, what they do is governments or donors commit in advance to subsidize a product if it's invented, and they set the quantity of the product that they will subsidize. And so an example of this is the $1.5 billion commitment that a group of countries made to subsidize a pneumococcal vaccine if one was developed that covered the strains of the disease that were common in low and middle income countries. And indeed, the vaccine was invented and the subsidy was given. Now, the reason why this is different from patents, which is the normal way that we use to stimulate innovation, is with patents, the incentives are such that you want to produce a relatively small quantity of the product and sell it at a very high price. And that's just really inefficient from an economic point of view. And only once the patent is extended, comes to an end, does the price come down and lots of people get the product. With an AMC, it's structured so that the incentive from the start is to get the innovation out to as many people as possible, because you want to get that subsidy, which is tied to the amount that you manage to sell it at. And indeed, you can structure it so that the producer has to charge a low price, and therefore it gets out to lots of people, which of course is really important if you're trying to do, say, a vaccine that's relevant for low and middle income countries. So the best example of this is the pneumococcal vaccine, which I mentioned a moment ago. And this was invented, but more importantly, it got out to a large fraction of the children who needed it much more rapidly than most vaccines. So by estimates about, within 6 years, enough vaccine for 50 million children was being produced every year. And that was about 5 years faster than we normally get vaccines out. And speed really matters because vaccinating 50 million children a year would reduce deaths from pneumococcal disease by about 230,000. So if you speed it up by 5 years, you save an awful lot of lives.
So that shows us there's a great deal of potential for advanced market commitments. And one of the questions one might ask are, why aren't there more? Why aren't we doing it for more? So my follow-up question is, what are the challenges going forward for utilizing this tool as an alternative to the patent system to generate, especially public health interventions, though I also know that you think about climate interventions as well. Is it finding the right target? Is it setting the benchmark payment? Is it finding the financial support, even though you know that target? You're in the trenches. What are the biggest challenges?
Yeah, so kind of all of the above, but some of these are overcomable, right? So finding the right target is really important. So because I'd worked on advancing vaccines during COVID, when I was working for the British government, Eric Budish and others of us were working on how to speed up a COVID vaccine. And it turned out that AMC was not the right way to speed up a COVID vaccine. Why? Because an advanced market commitment is very good at making sure that only the people who have a high probability of success stay in the race and work on developing the vaccine. Whereas in COVID, we wanted, even if you had a very low probability of success, we wanted you to keep going. So you didn't actually want to use an AMC. So here at the University of Chicago, we have a center called the Market Shaping Accelerator. And the whole point is to say, take a problem and figure out what is the specific market shaping mechanism that works for that. Finances, there are a lot of innovations that would save the world hundreds of billions of dollars or tens of billions of dollars. So these are very valuable innovations. But then if you're going to commit to purchase those innovations or subsidize those innovations, we're talking about raising, tens of billions of dollars to make them happen, which is not an easy thing to do. But the benefits are huge. Like we're coming up with, benefits 6-10 times the amount of the costs. But I think the real problem is the political economy, which is the whole point of an AMC is to keep it open, because anyone can win. Like you don't pick winners. You don't pick which firm you're going to invest in. You say, whoever does the best vaccine, whoever does the best climate change technology, we'll buy it if you produce it. Which means that there's no one firm who's lobbying for this to happen. Right? Because there's no senator that knows that the firm that's going to win is in their state. So the very fact that it's efficient and competitive means that there aren't a lot of rents, and therefore there's no one firm that's saying, okay, we really need this to happen. So that I think is actually the challenge. But I think there's huge potential and huge benefits. So I hope we can get over the political economy challenge.
That's great. And we're going to get back to some of the challenges of finding a mechanism that both balances a good price and innovation in a second with Meena. But first, I want to riff off of pneumococcal vaccine, low-income countries, and switch to a different disease, polio, around the world, actually. And I want to talk a little bit to John about Rotary International. It played an important role in reducing polio cases as a founding member of the Global Polio Education Eradication Initiative. Can you tell us both about the contributions by Rotary members and Rotary International, its advocacy on this matter, as well as what you think are the key accomplishments of this program?
Well, the polio eradication effort, I think, is probably one of the most successful, one of the more ambitious global health initiatives in history. And what's interesting about it is, as you mentioned, it really began with Rotary, a nonprofit, not a multilateral institution, not a Ministry of Health. And it was in 1979 that smallpox had just been eradicated. And Rotary was looking for a signature project to commemorate our 75th anniversary. We were established in 1905 here in Chicago. The first club was here in Chicago. And so we said, why don't we try to eliminate, if not eradicate, polio in the Philippines? And that was so successful that in 1985, Rotary had the audacity, and I think that's the right word, the audacity, to say, let's see if we can eradicate this disease for the second time in human history after smallpox. And so we were joined in 1988 by WHO, CDC, and UNICEF, and we created the Global Polio Eradication Initiative. And at that time, the world had about 350,000 cases of polio a year. It was in 125 countries. And so when the effort began, we've since then vaccinated 3 billion children. 10 million paralyzed children were prevented as a result of this effort. 1.5 million deaths were prevented. India went polio-free in 2014. No one thought that would ever happen. 2020, Africa, the wild virus was eradicated in Africa. Now, the challenge with polio, of course, is there's 3 types of polio. Type 1, type 2, and 3, unlike smallpox, which was just 1. So we've now eradicated type 2, we've eradicated type 3, we're just left with type 1, which unfortunately is the most virulent form. So from those beginnings, we're now down to just 2 countries, Afghanistan and Pakistan, where the wild virus is still circulating. We've had 5 cases in Afghanistan and 5 in Pakistan this year. So we're very, very, very close to really eradicating the disease. So what are some of the challenges we faced to get across the finish line, and then what were some of the lessons learned? I mean, polio, the only reason we've been able to get close to eradication is through the oral vaccine. There's two polio vaccines, an injectable and an oral vaccine. The beauty with the oral vaccine is anyone can be a vaccinator. And so you had hundreds of thousands of Rotarians going around the world vaccinating children, putting 2 drops of polio vaccine in children's mouths around the world. But you got to get to the children. And so it's not surprising that Afghanistan and Pakistan are really our last 2 countries, because in the pockets of where we still see the wild virus circulating, they're in conflict areas, hard to reach areas where there's sort of significant cultural pushback to vaccination. So our goal now is to try to get across the finish line, is to focus on the 0-dose children. In other words, those children have never been vaccinated. And what we're seeing now is that the wild virus is really sequestered in a number of what we call consequential areas in Yemen, Somalia, Pakistan, Afghanistan, Nigeria, and sort of 6 countries. So the idea is to get physically to the children, vaccinate them. And of course, very often you need to come back 2, 3, 4 times to vaccinate the children. And the other challenge is financial. $4.8 billion budget we have to get us across the finish line. We're still about $1.1 billion short. So what were the lessons we've learned and that can be applied to other initiatives? And I think the key one here is this was an extraordinary partnership where each of the partners, and by the way, the Gates Foundation joined us later, and then more recently, Gavi is part of the GPI, the Vaccine Alliance. What we learned is partnership is critical. And each of the partners in the GPI had a unique, distinct role to play. We coordinated efforts, we stayed in our lanes, and it's really through that partnership and those coordinated efforts that allowed us over the last 35 years to maintain that consistent effort to try to get across the finish line. And finally, my last point is that I often get questions like, well, wait a minute, you're down to 10 cases and you need $4.8 billion or whatever. That's insane. Why aren't we focusing on other diseases? And other people say, well, really, tuberculosis is the big one, or malaria, or HIV, or whatever. And I said, if you're interested in these other issues, you damn well better be interested in polio. Because if we were to fail, and we won't, but if we were to fail, good luck trying to put together a similar global initiative in other areas. And so we need to eradicate polio, not just for the sake of polio, but really to show that this can be done and to continue to set the stage for similar types of initiatives going forward in the future. And then finally, we've developed through the polio effort an extraordinary platform, extraordinary system, surveillance, laboratories, etc. That is really a gift to humanity. When Ebola broke out in West Africa, we were able to repurpose a lot of the polio infrastructure to deal with Ebola, similarly with COVID. And so I think as a global health community, we need to think through how do we preserve the polio infrastructure once it is eradicated, because it really is a structure and a gift to humanity that we need to make sure we preserve to be able to enable it to continue to be used for other significant, important global health initiatives. So it's a really interesting question. It's one that, I don't think in history a nonprofit has really had the audacity that Rotary had. And I think when we eradicate polio, I personally think all of the members, all the partners in the GPI deserve the Nobel Peace Prize. Yeah.
So I want to, so that's impressive. But I want to pull back from looking at that one program and think about Rotary broadly. And I think a few years ago, I visited Rotary up in Evanston and learned something fascinating. I wasn't familiar with Rotary, but the way that they select international development projects, not just polio, but other projects. And I recall that the thing that made Rotary distinct is that they had a decentralized approach, meaning members choose the policy, Rotary International selects amongst the proposals, funds those that it selects, and then members play a critical role in implementation. First, tell me if that's correct, if that's still a good summary, or whether there's been a shift. But then either way, tell me, how should we think about the pros and cons of that particular approach to selecting projects versus others? And the reason why I ask that is I'm sure Rachel also has an alternative approach that she's overseeing, whether she was at the UK government or now directing funds at a lot of, advising foundations on where to invest in development projects. Tell us a little bit about this decentralized bottom-up approach at Rotary.
Well, Rotary, we're organized around so-called Rotary clubs. We have 46,000 clubs around the world, 1.4 million Rotary members. You know, it's 75% of our Rotarians are now outside the United States. So we're an extraordinarily, but very balkanized and very decentralized global platform. I like to say there's almost no very few politicians in the world don't have a Rotarian as a constituent, which makes us an incredibly strong force for advocacy, which was a big role that we played in polio, in addition to the $2.7 billion that we've contributed to the effort. But I know it's really a combination of bottom up, top down. All our clubs raise money, they do their projects, they make a difference locally, internationally, they do what they want. At the same time, we have centralized our Rotary Foundation, again, based in Evanston. We raise about $450 million a year, and that we give $150 million to the polio effort, and the other $300 million is granted out to our clubs around the world to do projects. So centrally, we push certain types of projects if they want to obtain those grants, yet locally, they're able to do what they wish with their own funds. And so it's really a combination. I think it's really that combination that has allowed us to be so effective to undertake something like polio, to do other similar large projects, which we are doing, but at the same time allow our Rotarians to focus on those things that locally are extremely, extremely important.
So the key correction you're making is that there's two levels of decision making. There's the local one, for the local Rotary clubs, and then there's a centralized one, and it's both levels that are doing different levels of activity. But your original example was at the top level, but they're playing.
Well, we're able to really capitalize on both of our strengths. One is that decentralized local connection and community, but at the same time, because we have this enormous platform to try to put together economies of scale and drive certain things from a central position.
Okay, so that's great. And hopefully we'll come back to a little bit more about capital reallocation. But before we do that, I want to get the other two speakers involved. As I said, there's an international flavor and a domestic flavor to this panel. So I want to switch now to the domestic, and I want to start with Alex. So Alex, Mark Cuban Cost Plus Drugs is an interesting company. It reimagines the manufacture and distribution of generic drugs in the United States. It manufactures, at least I thought of as until last night when we had dinner, and at dinner you told me it's more than just manufacture. There's outside sourcing as well. But a key feature is there's the cost of either manufacture or sourcing. You add 15% and I think a $10 fee, and then you sell it, and dramatically reduces the cost of generics, maybe branded at some point. And the social media, at least the social media that the circle I'm in, is abuzz about the savings that this has generated for consumers. Can you explain the predicate, the problem that you're solving? So explain why it is that prices for generics, which are supposed to be off patent, are still so high, and how you are able to either manufacture or source them in a manner that's cost effective, let's just say lower cost, and distribute them more cheaply than other companies. How are you able to do what you do?
Yeah, absolutely. Yeah, so just to give a sense of scale, there are products on our site, probably a couple dozen, that fall into this broad category of ultra high cost generic products, specialty generics, however you want to refer to them. Just one example, imatinib is a chemotherapy drug, treats a condition called chronic myelogenous leukemia. If you have conventional insurance with a high deductible plan, the actual amount you'll be asked to pay out of pocket, the so-called actual adjudicated price, not the fake list price, but the actual amount out of pocket is $3,000 for a month's supply. Now, the exact same drug from the exact same manufacturer on our site is about $30 for that same month's supply. And when people hear that, they don't believe it. Is there some, what's going on? And although, as you correctly identify, there's no longer a patent granting a monopoly to the manufacturer on this product, there de facto is a monopoly on the distribution of this product from these entities called pharmacy benefit managers, which are increasingly in the limelight. Before, as a doctor, I had never heard of a PBM. I generally say people fall asleep before you're finished saying pharmacy benefit manager. But effectively, I try to keep my conception of them big picture, because I think the methods they use to construct their monopolies are incredibly convoluted and complicated. And, I like to say I used to study real things, MRI of pediatric kidney diseases. Now I study nonsense, which is the various scams that are used. So, why are the specialty generics so expensive? They're specialty pharmacies set up by the big PBMs that they mandate that people that have insurance plans that feed into them, which is basically everybody in America, have to use the pharmacies that they themselves own. And surprise, surprise, the prices aren't that great. But effectively, they've constructed monopoly, oligopoly on the distribution of pharmaceuticals in the United States. The Rand Corporation has a famous statistic that our pharmaceuticals here cost about 2.56 times more than in comparable developed nations. And certainly a part of that is the pharmaceutical companies do get more. But in our estimation, probably at least about half of that is just the fact that our distribution systems are so inefficient and there's so much rent that's captured in that distribution step.
Okay. So I hear that. And it's important that you separated the generics from the branded in that discussion. But I want to talk about the middleman that's in the middle. Okay, so we are at the University of Chicago. We have a very famous economics department. So we believe in trade-offs. Yeah, that's not so unknown. And so I want to push a little bit on the trade-offs. So let me try to articulate the argument. So one of the arguments, so you've already made the argument that PBMs, pharmacy benefit managers, they're middleman, they charge a markup. That markup can be quite exorbitant. That ultimately harms consumers. But there are also some folks that defend pharmacy benefit managers, and they make the argument that, look, if you're an insurance company, employer, and you want to get your employees, beneficiaries, access to drugs. There are lots of manufacturers, both generic and branded, you have to negotiate with. The PBM does those negotiations, so each insurance company, each employer doesn't have to do it themselves, and that reduces the total transaction costs of getting access to drugs for your employees or beneficiaries. Okay, so one question that one might have is, if cost plus drugs are success, if that company is successful and it reduces the power and markups that PBMs have, that reduces their ability to help insurance companies and employers negotiate with a lot of these companies. And in the interim, as that transition is occurring, before you even get to that particular bad outcome, you might have a situation where PBMs try to say, hey, look, where I'm working on a drug where cost plus has really reduced my markup, so that I have to reduce my markup in order to compete, I need to shove those markups onto somebody else to cover my costs. And so are we going to see some generics fall in price and the generics that you're not working in increase in price? Is that something we should be concerned about?
Oh, no, that's a great question. And let me sort of take it piece by piece. So to the question of, is there a role for PBMs? I certainly think there was, like it was when they started out in like the 1980s, 1990s, They initially started as effectively payment processing firms before, computers were as big a thing as they are now. But eventually they got to a point where they realized, hey, we're paying for all the drugs anyway. Why don't we also negotiate the price of the drugs? And now when I speak to sort of junior level, sort of low level employees at the big PBMs, they are told, like, you are the only line of defense between America and big pharma. Like, without the PBMs, pharma companies could charge whatever they wanted. However, when I talk to the senior executives at the same big PBMs, they say things that are not polite enough for me to say in a family audience. But they're like, yeah, we know what we do. And when I talk to the mid-level employees, they actually come up to me and kind of quiet and are like, thank you for what you're doing, because we know what's going on and we know it's wrong. Effectively, is there a room for effectively collective bargaining for the price of drugs? I mean, that makes a lot of sense. But Medicare now with the IRA is going to be negotiating drug prices. And that's a great thing. But we already had negotiators for drug prices in the United States. Each one roughly negotiates on behalf of 100 million people. Why are our drug prices worse than Lithuania's? And I think it's because the PBMs are in a very unique position where they're both monopolies and monopsonies. They both have a purchasing monopoly and a buying monopoly. So they have no obligation. So they can command incredibly good costs, but they're under no obligation to pass them along. And that's what you see wind up happening in spades. Effectively, our prices here are actually better than in most other countries behind the scenes. Like, one of the most common requests we get at Cost Plus Drugs is Canadians asking to buy drugs from us because our prices are better than in Canada, because we have 300 million people in the United States. Canada has 40 million. We're able to negotiate better prices. It's just that because there's this selling monopoly as well on the part of the PBMs, those prices are not actually passed along. They're substantially inflated through a variety of different mechanisms, be that Swiss subsidiary group purchasing organizations that capture part of rebate dollars, be that virtual manufacturers set up in the Cayman Islands that the PBMs can purchase from themselves drugs, be that captive pharmacies that can dictate the reimbursement rates to other pharmacies. Imagine you're an independent pharmacy, CVS Caremark gets to decide what your reimbursement rate is. Surprise, surprise, it's not very good. And it's estimated that a third of independent pharmacies might go out of business this year. So you see all of these massive externalities from these monopoly actors. So in principle, yes, absolutely, we should have negotiators on our behalf with big pharma, but they should be incentivized to actually but they should actually have to pass along the savings that they negotiate versus capture that value.
Great. And you brought up the IRA, so we're going to talk about that in a second. And you've done nicely talking predominantly about generics and how to reduce costs, to meet the expectations that we have of generics. Let's then turn to branded. So Meena, I want to ask you about the Inflation Reduction Act. An underappreciated, except in maybe our circles, an underappreciated component of the Inflation Reduction Act is a provision that enabled CMS to negotiate the prices of a small number of branded drugs that drive a substantial portion of spending under Medicare. Can you tell us a little bit more about that provision, its potential, how CMS negotiations with drug companies are progressing? I know we're in the middle of identifying companies, and then there's supposed to be a proposal that comes out, supposed to have come out in February. Can you tell us a little bit about that process and how the initial maximum fair price offers in February, how they're faring, or how you evaluate them?
Yeah, absolutely. And it's great to be here with all of you. Thank you for having me. So I wouldn't say that it's an underappreciated provision. It's probably the thing that I get asked the most about, especially by our nation's seniors, who are constantly asking me, when is my drug going to get negotiated? So the Inflation Reduction Act, just to take a step back, the prescription drug law provisions, there are three main buckets to it. The first is changes to the Medicare prescription drug program. These are the biggest changes to occur since Medicare prescription drug coverage started in 2003. So you may know that now insulin is covered with no more than a $35 monthly copay cap. Previously, people were paying up to $400 a month for insulin, now no more than $35. Recommended vaccines, you don't pay anything out of pocket if you have Medicare prescription drug coverage. Starting next year, there is a $2,000 out-of-pocket cap, meaning that nobody with Medicare prescription drug coverage will pay more than $2,000 in a calendar year for covered prescription drugs, which is huge because there has never been a cap to out-of-pocket costs in the Medicare program. So I've talked to seniors on fixed incomes who are spending $7,000, $8,000, even $13,000 on prescription drugs in a year. So all of those provisions really drive affordability. The second provision, which I would say is the underappreciated provision, is the inflation rebates, whereby if manufacturers raise prices of certain drugs faster than the rate of inflation, they have to pay the difference, the delta, back to the Medicare program, so that it's a discouragement to have these runaway price increases. And then the third bucket is negotiation. So again, Medicare has never been able to negotiate drug prices. So in the law, it maps out the criteria by which drugs are selected. So starting with Part D drugs, which are the drugs that you take, like that you get from the pharmacy, most generally, looking at the top spend drugs, and there are various exclusions that are laid out in the law, like if the drug is from a small biotech company, or if it's for a rare disease, or if it's a blood or plasma-derived product. Following all of that methodology laid out in the law, we selected the first 10 drugs for negotiation. These drugs, the people who are on these drugs in the Medicare program in 1 year spent $3 billion out of their own pocket for these drugs. These are extremely expensive drugs used by a lot of people for things like diabetes, blood thinners, there's a cancer drug in the list, immunological therapies, and they are drugs that are brand drugs that do not have competition in the market. So the idea is that now Medicare can negotiate. We laid out in guidance how we would do the negotiation process. So the factors that we are considering are all based in the law. If you haven't noticed the theme, we take what the law tells us, which is usually at like the 50,000-foot level, that gives us the authorities that we then put out regulations and guidance from which to work. So the law laid out a variety of factors that we have to consider, including what is the unit cost of production and distribution? What was the R&D cost for developing this drug? What was the federal financial support for developing the drug? What are the clinical factors what is clinical efficacy for the drug? So we took those factors that are all laid out in law, there are a few more as well, and came up with, our guidance of how we would implement negotiation. So what we are doing is, for each drug, we are looking at what the therapeutic alternatives are for that drug and looking at the cost of those therapeutic alternatives, and then seeing, is this drug better, the same, worse? And it really gives us an opportunity to examine how these drugs work in the real world, as opposed to in clinical trials, because the real world is very different than a randomized controlled trial sometimes. So it's a very good opportunity for us to say, okay, we want to see what is the value of this drug in meeting an unmet need in our populations, in addressing the needs of different populations. How does it get to issues of equity and disparities? For example, is this drug easier to take, that it's easier for a caregiver to be able to help someone so maybe their health outcomes are better? So we provided a lot of opportunities. We had 10 patient-focused sessions for each of the drugs to hear from healthcare providers, caregivers, patients about the benefit of these drugs. And then we also have incorporated the other factors that I mentioned, like the unit cost of distribution, the length of patent protection, the R&D cost that went into it. And bringing all these factors together, we're now engaged in back and forth negotiations, which are good faith negotiations following that process. And I think most importantly here, it's really an opportunity to drive the conversation and bring more transparency around drug pricing. Traditionally, there's been a lot of work on the randomized controlled trials and evaluating, the efficacy and safety for FDA approval. and then it goes to market. And there's a huge opportunity to really understand what the benefit of these drugs are in the real world and how that should be considered in the price of a drug. And so, following the law, at the conclusion of the negotiation, when there are agreed upon prices, then CMS will publish a narrative describing the data that went into play, what was the agreed upon price, and that is information that can then be used by anyone. It can be used by health plans, it can be used by providers, it can be used by manufacturers. So it, not only is this impacting drugs that millions of people take in Medicare, but it also provides an opportunity to really drive the conversation of what changes drugs are bringing to the healthcare system and to people writ large.
Okay, so that's very interesting. You are actually circulating among constituents, so you know that the most common question was, why don't we do this more? I'm sitting here at a university, and so we get the opposite question, why are you doing this? So let me push on my question, but you can feel free to elaborate on the opposite, which is why we should do this more. And I think that your answer is going to get in that direction or push in that direction. So I'm going to tell you a little bit about a concern, which I'm sure you've heard and dealt with before, which is one of the difficulties with the maximum fair price provisions is that it's going to reduce prices and thus the returns to innovation. And so you might have less invested in R&D. And these critics make two types of arguments, as far as I can tell. One is that while costs of drugs rise, drugs obviate the need for other healthcare interventions, such as hospitalizations. And so once we include those savings, the actual costs are a little bit lower. And or they make the argument that financing innovation is a little bit complicated at drug companies. Drugs that have failed clinical trials, those have to be subsidized, and they're cross-subsidized by drugs that pass clinical trials and are blockbusters. And so those high profits are used to funnel R&D that a lot of time fails. And so if we look at risk-adjusted returns on drug companies, they don't seem out of whack relative to what we expect in competition. Now, I'm sure you face these kind of pushbacks. How do you answer them and or kind of alleviate concerns about them?
Yeah. So starting with some facts, when we announced the 10 selected drugs, the stock market didn't move at all for those manufacturers, which I think is a pretty good indication of where people see that innovation and that the market will continue to thrive. Bayer announced that they are increasing innovation, R&D in the United States. I think JP Morgan recently announced that they are investing in biotech in the United States. I was on a panel at Milken Global where the CEO of Amgen said that his outlook for the next 2 years is more innovation. So I think this is just looking at some of those facts, I think it's showing that in the stock market, in the earnings calls, that there is not that concern. The question may be why? I think a big factor is that there's a big difference between Me Too innovations and breakthrough innovations. And what we are trying to do is really reward the kinds of innovations for cures and therapies that people need. Being able to say, okay, provide data that shows how this drug improves the lives of people. And importantly, to something else you said, it is thinking about that fuller cost perspective. If this drug is keeping people healthy and avoiding hospitalizations, that is something that should be taken into consideration. So being able to bring that more holistic perspective so that you are able to reward innovations that are important innovations for cures and therapies, not necessarily just Me Too innovations. I think the other important point is that there are many provisions in the drug law that actually are improving business for pharmaceutical companies. There are a lot of provisions that they support, like the $2,000 out-of-pocket cap, like the $35 insulin copay cap. There's also a provision where people can spread their out-of-pocket costs over the year. So if you're going to the pharmacy, instead of getting stuck with paying $1,000 to pick up your prescription, which presents huge cash flow issues to people on fixed income, you can instead spread that $1,000 out over the year. So what does that mean? People are actually able to get the drugs they wanted to get before, which means, increased demand for pharmaceutical companies. So I think those factors together, number one, that innovation is central to how we are approaching negotiation. And number two, you can see that the way the market is responding, that, there definitely is that rhetoric. And I think there's also the way that things are playing out.
So I want to push on that for a little bit, and then I have a question for Rachel that's going to be related. So let's look at the opposite side of that. And both you and Austin said, you're wearing your government hats and you say, we act within the law. But you also probably think about future dangers. And so dangers are potential, I should say. I should be very careful about that. One thing that seems just around the bend that's important is that we've got these GLP-1 agonists that are going to be a dramatic change in how we handle a range of issues, starting with, say, obesity, although that's not the first disease that they address. There's this potential that there's going to be massive uptake. And massive uptake at the current prices are a massive expenditure. And so we have to think about how we get higher quantity at lower prices in order for it to be feasible. Have you begun to think about that? I know that there's nothing in law about this, but surely there's some planning going in to how do we address this great potential going forward?
So there actually is law about this. So the Medicare law states that drugs for weight loss are not covered by the Part D program. So where these drugs, so take the example of Ozempic. Ozempic is a GLP-1, and GLP-1s are in the treatment guidelines for diabetes. So for an indication of diabetes, the drug is, on formularies because we review all formularies in the Medicare Part D program to make sure that they're following clinical guidelines. GLP-1s are in the clinical guidelines for that indication. Wegovy is another, anti-obesity drug that just got an indication for cardiovascular disease. So we notified all of the plans that administer the Medicare prescription drug program saying, okay, you all see that now there is this indication for cardiovascular disease. Here is how you can go about, adding it to formulary. So where these drugs have indications aside from weight loss, then they can be on the formulary, but there actually is, in the law, it says that drugs for weight loss are not on the formulary. So this is, it is the constant theme of where the Medicare law is, Medicare really is like 3 layers. There's the Medicare law at 50,000 feet that provides us with our authorities, within which then we put out regulations at like the 25,000 foot level. And then you get to how care plays out on the ground. So I get people coming to me saying, Medicare needs to intervene and make my health system pay primary care doctors more. There is something called a non-interference clause where the Medicare program cannot get involved in contract negotiations between private entities. It's the same with what Alex was mentioning between the pharmacy benefit managers and the pharmacies. In Medicare law, there's a non-interference clause that we cannot step in and set prices that the plan and the pharmacy are negotiating with each other. On the flip side, it's like people will say, well, Medicare, you should pay for telehealth, all telehealth. There is a provision in the Medicare law that sets restrictions on how telehealth can be utilized. So for those issues, it goes to, so for the first set, it goes to the plan or the health system. For this set, it goes to Congress. So, when we're talking about things that are related to the Medicare law, those are issues that Congress has to take up. And then we implement accordingly. So,
so that's fair. But I still need someone to talk to about finance. So I'm gonna turn to Rachel and ask you a question, and I'm gonna shift focus from the U.S. to the UK. So as I mentioned in the beginning, you were chief economist at the UK Foreign, Commonwealth and Development Office, and before that at DFID. During that time, if I remember correctly, you saw the UK pull back on foreign aid for, among other things, public health. I was on the other side of that as someone seeking to raise funding for projects. But so there's a public pullback from public health projects in lower income countries. What do you think are the causes of that move and some of the consequences that we might be seeing now of that move?
Yeah, so you're right. Unfortunately, I was in the position of having to think through prioritization at a time when the aid budget was being quite severely cut. And that was due to COVID. So in the UK, the aid budget is linked to the level of income, the national income. And so when income fell with COVID, it fell. And then then there was a political decision to cut the percentage of income that went to aid, again, because of COVID. So in the middle of COVID, when there was a big increase in need for aid, we had to make these quite strong cuts. I would point out, however, that the UK still spends twice the percentage of its income on aid than the US does. So we're still, it was a big cut. It was a very painful cut, but it's still a big supporter of aid. In terms of the impact, it was very difficult. I spent most of my time in government, talking about cost effectiveness, trying to make sure that our budgets were spent on the most cost effective things. It turns out when you're cutting that sharply, even though they turn to the chief economist to help prioritize the cuts, there's so many fixed costs and contract obligations that actually it's quite hard to do it. You can't just cut the worst performing projects, unfortunately. Anyway, what are the impacts? I think one of the things I worry most about is, we've been talking a lot about innovation and the huge benefits to the world of innovation. And one of the things that the UK aid budget spends on is developing new technologies, new health technologies for low and middle income countries. And those have proved to be spectacularly effective, in general. So now countries have much higher health at a level of income that was much lower. At a level of income, if you looked at where the US was at that level of income, our health was much, much worse. So for a given level of income, health is now much, much better, mainly because of the improvement in health technology. And so that's where I worry most about the cuts in aid. And I hope other people will, it was to some extent protected. That area of innovation was to as much as we could do, protected from the cuts, but it is something with very high returns, and I hope other people will step in and help out on that.
So I want to pick up on one particular statistic and bring it back to the US. So UK spends more per unit of income than the US does on foreign aid. And I know that, John, you've thought about this. So back, as I mentioned earlier in your introduction, 2004 to 2009, you were the VP of Operations and Compact Development at Millennium Challenge Corporation. The debate over the value of foreign aid to recipient countries. Rachel has talked about it in terms of its public health impact, but you've made a separate argument, which is it's in the national interest. It's in our national interest, the U.S., to engage in foreign assistance. And I think that it's important for people to hear your views, especially at a time when in the development economics community, there is a debate about what the value of foreign assistance is to the recipient. You're making a slightly different argument. Can you spell out your argument, please?
Well, I think one of the challenges we face in general in the foreign assistance space is there's a huge misperception in the public. If you look at the various polls, most people say, 25% of our budget goes to foreign aid. And it's literally less than 1%. And so I think there's a huge education gap here in terms of what we're actually spending on foreign assistance. As Rachel mentioned, the U.S. is at 0.2%, well below the 0.7, kind of floor that everybody or ceiling that we're looking at. Now, I think the argument, it's pretty self-evident. There's the economic argument. Sort of 95% of the world's consumers are outside the United States, and to the extent we can use foreign assistance to strengthen economies, strengthen export markets for ourselves, that's good. Like 1 out of 5 U.S. jobs are dependent on international trade. 1 out of 3 manufacturing jobs are as well. It's 12 of our top 15 trading partners received at some point significant U.S. foreign assistance. So it's in our economic interest to create markets for our exporters. Obviously, the moral argument. You look at the good we have done. Look at the polio eradication effort. The United States is the largest bilateral donor to polio, largely funding it through USAID and CDC. A lot of good has been done. I was in the Bush administration again when we were establishing the Millennium Challenge Corporation, but the other great initiative that President Bush had was PEPFAR. that dramatically attacked the issue of HIV in Africa. So you've got that sort of the moral argument, and then there's the national security argument, and that's again self-evident that countries that are stable, prosperous, market economies, democracies tend to be less belligerent and less problematic than those that are not. And so I think there is a compelling argument. It's just we've not done a good job of selling it to the public. And so that goes to the issue of what sort of foreign aid should we be doing? What's wrong with what we're doing? And that's why I was so excited to be part of the team that set up the Millennium Challenge Corporation, because we were designed not to compete with AID, but to deliver the assistance in a new way. And what did that mean? It meant we established 17 objective criteria, non-maintained by the US government, that countries had to meet in order to become eligible for funding. In which they passed the test and earned their way into the program. They then got to choose what we funded. They got to choose. You had this issue of country ownership. And then they were accountable. We had strict M&E, and if you screwed up, you'd get kicked out of the program. And that's very rare in the international development space to kick anybody out. We kicked out Madagascar. Subsequently, after I left, they kicked out Burkina Faso and Mali. And this sells well, because when I joined MCC, my mother asked, and she's sort of a bellwether for flyover country thinking. My parents have passed, but they lived in Detroit. She says, John, why are you going to do this? You're just wasting U.S. taxpayer money. It's going to go to roads to nowhere, white elephant projects, et cetera, et cetera. And I said, here's how MCC works. You want to get into Harvard? You got to get great grades, get good SATs, and earn your way in. And once you get in there, you get to choose your courses. And you're responsible for getting your good grades. And if you screw up and get bad grades, they're going to throw you out of the university. And she goes, oh, wow, that's cool. I get that. Okay, let's do it. So I think there's significant, obviously self-evident, there's benefit to our foreign aid programs. We have to just structure it in a way that makes sense. I'm delighted now that the MCC principles are being adopted, and certainly by AID and others. And I think in 2022, MCC was rated as the world's most transparent bilateral aid agency. And it continues to have bipartisan support in Congress. But we need to do a much better job of selling to the public the value. And it starts really with just simply that canard that 25% of our budget goes to foreign aid. And it's simply not true.
Okay, so we're reaching the end of our hour, I think. So I want to ask one last question before, if we have any time left over, open it up to audience questions. And I want to make it a little bit more fun. I want to go back to Alex. Everybody loves good origin stories. At least I love good origin stories. And you have a very interesting origin story for how cost plus drugs becomes Mark Cuban cost plus drugs. Tell us a little bit about, I learned a little bit about this last night, Y Combinator, your experience there, how Mark Cuban, how you approached him, and how you ended up where you are now.
Sure. So do you guys remember this character, Martin Shkreli, the pharma bro? Yeah. For those who have the good fortune not to remember, he was sort of a social media kind of like villain of the week, long time ago now, back in like 2015. Young hedge fund manager. He bought the rights to a generic drug company and massively marked up the price of the drug, and had sort of like a histrionic personality. Got a lot of social media flack, and I got together with some infectious disease doctor friends of mine at the time and decided, with all due naivete, hey. Why don't we start a non-profit pharmaceutical company? We'll make the drugs, we'll sell them at cost, it'll be great. True to that, we started a 501c3 and went around sort of hat in hand trying to raise money for it for the better part of 3-4 years, and did not succeed, failed spectacularly, did not raise a dime beyond what I put in myself. Eventually applied to Y Combinator, which, for those unfamiliar, is a venture capital firm in Silicon Valley that has open applications, a so-called accelerator. And they periodically donated to nonprofits. So I went and interviewed with their partnership. Actually, my interview panel was a guy who was then obscure, now is pretty well known, Sam Altman. I interviewed with Sam, and what he said was, hey, we like what you're doing, we'd like to support it. I remember he pulled me in the back and was getting a cup of coffee. He's like, we don't think you'll be able to raise enough money to get this off the ground as a nonprofit. Like, pharma companies are very capital intensive. If you reincorporate as a public benefit corporation, so for-profit company but with a public mission, we'll invest in you like we would in any other company. And perhaps now I shouldn't admit I took corporate governance advice from Sam Altman, but Turned out he was right. He was right in this case. He, after working with Y Combinator, came out of their batch, was able to raise what in pharma dollars is not a lot, but a little over $1 million to get us kicked up and off the ground. And yeah, a few months after that, actually around the time of the last pre-COVID Marshall gathering, I remember Meena and I had dinner there in Aspen. I just on a whim emailed Mark Cuban because he has a public-facing email address. And yeah, he got back in like 5 minutes. Like, if you guys want, my favorite party trick at conferences is to, Mark's email is mcuban@gmail.com. If anyone wants to email him, he'll probably get back to you before. Yeah, I have no idea how he does it because I'm bad at email, and he gets 1,000 times more emails. It's incredible. But yeah, we got into a dialogue, and he invested a small amount of money to start with, and yeah, obviously became much more invested over time.
Yeah. All right. Well, with that, do we have time for a few minutes, or how are we doing on schedule?
Maybe we can collect a few, and we'll just do like one session.
Sounds great.
So you can find them to continue. So I want to push that. First of all, Alex, huge fan. I've been a fan for years, and John, I'm now a fan of yours. But I actually want to push Meena a little bit on the innovation question, and maybe Rachel. So big pharma does have a problem in that its approval rating is below Congress's, and sometimes for good reason. But the other problem is that big pharma doesn't do innovation. It acquires all of it from the biotechnology industry. And the feeling in the biotechnology industry right now, since 9 out of 10 of them fail, is that if the Inflation Reduction Act is implemented as planned, it will kill the biotechnology industry. So there is going to be a downstream effect, which means there will not be this innovation market for big pharma to access. I agree with many of the things that you've outlined, especially looking at marginal drugs and not paying full dollar for marginal benefit. But the reason that we are so expensive is not because big pharma is this bottomless pit of capitalist greed. It's because we subsidize medical innovation for the entire world, including Europe and Asia. And I've often thought a more effective way to tackle this problem to ensure that they're contributing their fair share is maybe a negotiation that said, hey, we'll pay the same as your next lowest purchaser, which would then perhaps potentially encourage other countries to start paying their fair share of R&D, all of which currently happens in the United States.
I don't know if do you want me to respond?
No, let's take a few.
You're taking a few? Okay.
Hi, Rahul Reiki, 2013 Marshall Scholar. So one of the, as I think ahead about health policy challenges as they relate to pharmaceuticals, one of the challenges, it seems to me, is the fraying of the compact we've had around new drugs, which is drugs come on the market, they're perhaps more expensive than they should be, but over a period of time, they become genericized, and that becomes much more sustainable for the budget. And with obviously the newer classes of biologics that are coming on the market, that notion of genericization, to use my earlier word, is fraying. We've already started to see that with biosimilars and monoclonal antibodies, for example. But as you have gene therapy and other, RNAi, other modalities, that becomes even more challenging. So I'm curious how you think about that. Does that require, in some sense, a different framework? Do you think technology will catch up and make those biosimilar type products interchangeable, even for new modalities? Just, again, curious how you conceptualize that problem.
Should we take one more if there is, and otherwise we'll have the panelists respond.
Just have a question from John from Rotary International. You mentioned this kind of unique top-bottom approach that Rotary engages in, and I've been involved in that with a project that a group of my students did in West Africa, and Rotary comes in Wisconsin. I guess what I wondered is if you could talk a little bit about maybe the impact of that in terms of our democratic politics, because if we reflect back on some of the other panels, we talked about divides in the U.S. between the educated and the non-educated, between rural and urban areas. And I wondered if you had any thoughts on how these kinds of projects may help people who are really not very educated in perhaps a professional sense, become involved in international development efforts and how that might then be connected to broader goals of U.S. foreign policy or the state of our democracy. Thank you.
All right, so let's go ahead and have the panelists respond. Let's start with Meena.
Okay, I'm trying to remember the questions after a full day of meetings. So I think to, the points around innovation, a few thoughts. First, there is a small biotech exemption in the law, meaning that a drug that is from a small biotech company cannot be selected for negotiation, to get to some of the issues that you mentioned. But also, this is what underlies these drugs are on the market for a minimum of 9 years or 11 years before negotiated prices go into place, so that there is that opportunity for being able to recoup R&D costs. And actually, this also comes back to something I didn't mention earlier when you were asking about, well, R&D cost of this drug, but there are many other drugs that could have, failed before it. For those of you who really feel like geeking out, we put out things called information collection requests, where we take comment on the data that we are looking to collect. And we put out these ICRs, as they're called, for the data that we would collect with negotiation. And we laid out in there how we would want to get information on the R&D cost of a particular drug, as well as, and like, what do you include in that to get at, some of what you were speaking to. So I think, again, there are provisions in the law to address, some of those issues. And, I have been, since the time the law passed, it passed on August 16th of whatever year it was, 2023, 2022. I don't even remember now, because it's all been a whirlwind. We have been meeting with pharmaceutical companies, biotech, providers, patients. And, I really think that there were common themes about how do we make sure that you're rewarding the kinds of innovations that really serve people, that are really driving the needle on the next, phase of treatment, as opposed to innovations that just enable you to get around a patent or, something like that. And being able to make sure that people have access to whatever innovative therapies come about, so that they can actually take them, so that it has the intended effect. And I think that is a theme of, that underlies everything that we're doing, again, within the framework that the law establishes. I think for the biosimilar issue, there's also a provision around a biosimilar delay, that if it's anticipated that a biosimilar is going to come on the market, then a brand drug may not be negotiated. There are many other ways in which I think we can all encourage generics and biosimilars. I'll give one example. The FDA puts out materials on biosimilars. So for those of you not as steeped in healthcare, biologic drugs, insulin is an example. Like, oftentimes they're drugs that you have to inject. They're much harder to manufacture. They're large molecule. They have a lot of complexities and nuances in terms of how individual bodies react to them for treatment. And so when biosimilars come out, number one, they're harder to manufacture. Number two, it's stickier, because there are some biologics that are directly interchangeable, but biosimilars are not directly interchangeable the way that a generic is. So the FDA had all these materials kind of explaining, how biosimilars interface with the brand drug, for use. And we took their materials and distributed it to all of our providers who participate in the Medicare program to help with education, right? Because some of this is, you can have programs and policies and products available, but again, if you think about those 3 levels of the Medicare program, there's also what happens on the ground, and how do we make sure that things are actually being utilized and taken up. So I think that is an example of where, outside of the laws and the regulations that we're talking about, sometimes there are simple things you can do, like distributing materials, because people tend to listen to the organization that's paying them, right? And so being able to utilize our Medicare Learning Network to get out information on biosimilars as an example of how we can, improve uptake as well.
And let's, because we're a little over, we're going to do this quickly. If you can quickly answer the question about
Yeah.
democracy, that'd be great.
I mean, organizations like Rotary do an incredible job of bringing people together, bringing down cultural barriers, bringing down differences. We run one of the largest youth exchange programs in the world, 7,000 students every year. We send them for a year of high school. And it's not just into the United States, it's Taiwan to Slovakia, it's the UK to Brazil, et cetera, et cetera. Our projects, these top-down projects that I was telling you about, they're globally focused and they require 3 or 4 clubs from 3 or 4 different countries to get together and, let's say, do a water project in Benin or a literacy project in Guatemala. And what that has created is thousands and thousands and thousands of global citizens. So I'll visit a small club in a small town somewhere in the middle of nowhere, and I'll talk to them, and I go, what are you guys up to? And they said, oh, we've got our exchange student coming in from Zimbabwe, and then we're off to Honduras to do our water project, et cetera. So an organization like Rotary allows normal kind of just folks to partner together, tap into this incredible network, become citizens of the world. And I think that goes a long, long way. We need more of that. I think we had more of that. I think we'd see greater appreciation for democracy, greater democratic values, and less of this conflict that we currently see in our country and throughout the world.
All right.
Sorry, I got to chime in just because the biosimilar question triggered me, and I can't help myself. Sorry to waste everybody's time. You know, I would say the pushback against biosimilars, utter nonsense. There are 12 biosimilars of Humira, the world's biggest drug. 12 biosimilars came out at the same time. The adoption rate at the end of last year, less than 1%. Of the 99% was still with the Innovator product at AbbVie. This year, flip of a dime, 30% goes to one company. And what is that company? Cordavis. Anyone heard of Cordavis? It is CVS Caremark's white label of Sanofi's product. So, oh my gosh, there's all this pushback. You know, clinicians will never switch to a biosimilar. Like, it's too hard. Flip of a dime, 30% goes to Cordavis, 1-1 this year. So, you know, I think biosimilar adoption, if the PBMs wanted it to happen, and we have a product, we have Usimry, which is a biosimilar Humira, which costs about $500 for a month's supply. The Innovator is closer to $4,000 or $5,000. There's so much money spent on this drug that we could save 10% of all pharmaceutical spending. Not 10% on this drug, 10% of all pharmaceutical spending if we just switched from Humira to Usimry. And it's blocked. But I'll tell you this, Cordavis, still $4,000 for a month's supply. So take from that what you will. Sorry, you triggered me with that question. I had to get that in there. Yeah.
On that note, thank you very much.